нас утренние. Да, это утренние. То есть только две пока есть.
Мы ждем как-то всех остальных участников. Просто чтобы
Замой его кулемем.
Ну вот пока вообще не приходил, еще не было его.
он мне нужен очень.
Она стоит, да, думаю, она скинет. По-морозному часть.
Они сами, да, они запускают здесь, то есть докладчик садится вот в это кресло, запускает презентацию и переключает и рассказывает.
Perfect.
And это для перевода.
You know, I will use it then. Yeah. So, good afternoon, everybody. It's a pleasure to be here and to see you all. And let me introduce myself. I'm Rüdiger Hehlmann from Heidelberg University. I also coordinate the European LeukemiaNet. And to my left is Elsa Lomaja from the Almasov Center, whom you probably all know. So the topics we are addressing is something very up to date, because finally, after many years of no action, the situation in myelofibrosis is improving. We have some drugs that are helpful in prolonging survival with myelofibrosis and with alleviating symptoms, which is very nice. And then we have 3 presentations addressing various stages of CML. The one is given by Elsa Lomaja on the 2nd generation tyrosine kinase inhibitors in the 3rd-line setting, which is an important topic because, as you might know, in CML, we still have 5 to 7% of the patients progressing to blast crisis and not doing so well. So we have to do something on that. And then my neighbor to the right, Dr. Morozova from the university, from the Pavlovsk University, is talking about allogeneic transplantation, which is still an important mode of treatment for CML. And then Dr. Samoyeva, that is you are then talking on blast crisis of CML. You are talking on those patients, who have really a problem still now. So with that, having said, I like to get started. Time is running. And Elsa, if I may ask you to start with your presentation. No, you're the, who is the first one? The first one is, Kulemina, that's you. If I may ask you to start with your presentation on predicting the results of targeted therapy for myelofibrosis in real clinical practice, data from a multi-center study. So, Dr. Kulemina, it's all yours, and it's my pleasure to listen to you.
Professor Hehlmann, Professor Zaritsky would like to say a couple of words.
Oh, just wait a minute. I'm just informed that Professor Zaritsky, who actually would have loved to be here, but he is a little indispositioned, and but he likes to say a few words. So how do we do this?
They connect. And this is for you.
Yeah, Okay. Andre, do you hear me? We would be ready to hear. Oh, yeah, there I see you. Okay. Professor Zaritsky, we can't hear you. We can't hear you.
Да, Андрей Юрьевич, сказали, что если вас не будет слышно, просили по-русски говорить.
Something isn't working. Something isn't working, Andre. I'm very sorry, but
Maybe
maybe the people in charge, they can sort it out what is not working, and maybe Andre, you can comment later in the session or at the end, yeah, if we can proceed that way. And then now Dr. Kulemina, please, I excuse, for this confusion,
No,
but,
it's okay.
just start, please, now.
Dear colleagues, I would like to greet you once again. Allow me to report on the target therapy of myelofibrosis performed in the Russian Federation and predicting the result of this targeted therapy. When we are talking about the evaluation of the therapy of myelofibrosis, we base on our epidemiological data. According to as for the incidency, we use the large registers, Orphanet and ReaCare, where it's from 1 to 0.5 cases to 100,000, but we don't know if they include only the initial myelofibrosis or also post-thrombotic myelofibrosis. As for the prevalence, there is also some data. So it's from 0.5 to 2.5 cases per 100,000 population. It's the data from Europe, but in Russia we've got another problem. We don't have registers nowadays that include patients with myelofibrosis in the Russian Federation. There is no populational epidemiological data on the morbidity and the prevalence. In this situation, we can base only on the data of the initial incidency of initial myelofibrosis in St. Petersburg. Within the recent 10 years, we assessed the dynamics with the medium morbidity 1 per 100,000 population. When we talk about targeted therapy of myelofibrosis, we talk about two aspects. First, it's the impact on the quality of life of the patient, because the quality of life of such patients is much lower compared to the general population. Our colleagues' survey showed that the quality of life of such patients compared to the healthy people and the level, the quality of life, it was much lower. All the balls, starting from emotional to physical spheres, was much lower compared to the healthy people, and it was in a range of symptoms that are really very tiring for these patients. And the second aspect is the prolonging of the lifespan of the patients, because the lifespan of such patients is third less than compared to the general population. Our trial included 10 institutions from the Russian Federation. The result was published last year. This map shows the cities that united and took part in our survey, and they sent the data, the results, to St. Petersburg, and we analyzed them here. Our retrospective study had quite standard criteria of including, and the response level was assessed according to the spleen response as to IWG criteria and the palpable size of the spleen. As in our routine practice, it's quite difficult to perform MRI for such patients. The points for answers to RUX therapy was the reduction of spleen to the 3rd and the 6th months of the therapy, and the answers were divided into 3: reduction less than 20%, 20-50%, and 50 and more %. Here you can see the basic characteristics of the patients by the time of RUX therapy. In general, 56 patients participated in our trial, but we abandoned part of the patients due to the lack of data for assessment. So we had 42 patients to be assessed. The patients were younger than in other trials. The median age is 56 years, as you can see. Quite a large percentage of the patients, most of the patients, had massive splenomegaly. Moreover, about 90% suffered from constitutional symptoms. Among this clinical and laboratory data, I want to draw your attention to the level of platelets in these patients, because 60% of the cases, the level was more than 2,000 in microliter. At the same time, the initial dose of RUX was given to the patient in reduced level, 15 milligram per day, for 64% of the patients. The patients were stratified according to the risk groups, and mostly the patients in our trial were in the favorable group. It was about that. While assessing the periods of discontinuance, so the discontinuance within 12 months was needed only for one patient. The patient was with resistance and the disease transformed to leukosis. The discontinuance periods were rare, and also they were due to the difficulties with the providing the drug. While assessing the response of the spleen by the third month of the therapy, 25% and more were reached in 69% of the patients, mostly patients in the first group of risk. By the 6 months of therapy, overall response was in 72% of the patients. Here you can see the graphs of the individual reduction of the spleen in the patients by the third and the 6 months of RUX therapy. Besides, we have assessed the dynamics of the spleen size within the first year of the therapy, and we also assessed it in different categories of the patients. The level of the spleen reduction was minimum, no dear, and as you can see, the patients with poor response, a reduction less than 25%, the response was not significant within the whole period of therapy. We also assessed the overall survival, and we can see the improvement of overall survival in the patients of the spleen survival by 50% and more, and 25% and more by the third month of the therapy. Such tendency can be seen and the improvement of the overall survival by the 6th month of RUX therapy. The overall survival by the second year of the therapy was quite high and was 96%. Besides, we have assessed the predicting factors influencing the overall survival, and in multifactorial analysis, the confirmed significance was 2 factors: the initial size of the spleen and the reduction of the spleen by the 6th month, so it's the early response. As we know, the response, the spleen response, is not included in the predicting scales, but lots of surveys demonstrated this connection. The survey on RUX efficiency in first and second phase, it also correlated with the spleen response. Our data was comparable and even a little bit more to the data of RUX efficiency in the real clinical practice, both in the spleen response and the symptoms. The level of symptoms by the third month was 89%, and by 6 months, 54%. Overall survival was 96% by the second year, and the data was about 80%. As we can see, the data
Лучшим,
in general, our patients were younger with lower rates of risks, which accounts for many results, many outcomes that we have received in the study. The study Comfort 1 also spotted a number of tendencies regarding the improvement of the general survival rate by when measured on week 12 after therapy. However, no reliable results have been received. Spleen response was also measured. In summary, I would like to stress that patients in our study differed from those observed in clinical trials. They were younger, had lower rates of risk, however, had a large symptom burden and massive splenomegaly. In addition, the reduced size of the spleen by month 3 has prognostic importance. If it reduces by less than 25% at 3 months of Ruxo, it's a predictor for poor prognosis for the patients. And it's also an indicator for allogenic HSCT. We understand that part of our patients, despite poor spleen response, may not take the advantages of autologous SCT. And if the patient is stable, if the symptoms are improving, it may be recommended that they continue on Ruxo. For patients with intermediary response, dose escalation of Ruxo may be recommended. Patients may also be recommended to be included for inclusion to clinical trials, or prescribe different combinations with HU, hypomethylating agents, and interference. Reduction by 50% and more is a good prognostic sign and an indication to continue with Ruxo. I would like to thank Professor Andrzej Zaritsky, Ella Lamaya, and all the physicians, all the doctors from across the country who took part in our study. Thank you.
Okay. Yeah, thank you. Are there any urgent questions from the side of the audience? Dr. Morozova?
Ольга Владимировна, спасибо огромное.
Yes, dear Olga, I may have missed something, but I understand that most of your patients were JAK positive, JAK2 positive. Well, we collected the data from across Russia, and those were retrospective data. And we have the data about MPL for our patients, but for some of the patients, we didn't have molecular data available. Did you try to look at the thrombotic sequelae in your group and whether they were reduced? No, we didn't. And thank you. Some fantastic data that you provided, the patients whose quality of life is so much improved. You are planning. You mentioned combination with different medications. From your standpoint, what kind of combinations, if under the ideal settings, if you could choose any medications, what would you combine Ruxo with? I would say that the most promising combination at the moment is Ruxo plus navitoclax. But we understand the obvious complexities. We understand that the medication is in short supply, and this is not a viable option for most of the patients, apart from those that can be included into clinical trials. More accessible options include interference. However, the data is still insufficient. Thank you very much. You have done a lot of work. I can imagine how difficult it was to get data from across the country. Thank you. Congratulations.
May I ask you a question as well? Maybe I have missed that. Are these the final results of your study, or is that an interims analysis?
No, final. The final.
The final analysis.
Final results.
And what was the level of significance you have reached? You know, you say the survival with early spleen size reduction is significantly better. You know, what was the significant level?
I can show you.
Yeah.
Okay.
It was below the 5% limit. You know, I somehow didn't see the number.
Yep. Their significant level in spleen size reduction at 3 months was
yeah, there
zero?
it is. You know, I missed that. Okay, you know, that's what I wanted to see. Okay, thank you. One more comment. You are a clinical trialist. Yeah, you are doing a clinical trial, and the term you are using on your slide, real world, is a pejorative of clinical trials, because clinical trials are just as much part of the real world as observational trials. And so far, you know, realizing that the common term, which is internationally now used instead of more serious term, is in routine care, instead of real world in routine care. Yeah? So that way you don't, otherwise you jeopardize yourself. You understand?
Yep.
Okay, so thank you very much, and we now proceed to the second presentation. Yeah, you know, and it is not given by you, Elsa. It is given by a young lady, a co-worker. That is you, yeah, Tamara Chitanava. Chitanava? Yeah, okay. And Dr. Chitanava, she is talking on predicting the results of treatment with second-generation tyrosine kinase inhibitors in the third-line setting. Yeah? The results of a multi-center study in St. Petersburg and the Leningrad region. Okay, Dr. Chitanava.
Спасибо. Меня слышно? Да?
Okay, in routine care.
Good afternoon, dear colleagues. Thank you for the opportunity to present the findings of our study at the 4th St. Petersburg Medical Innovation Forum. As you know, these are the results of a multi-center study that was conducted in St. Petersburg and Leningrad region. First of all, I would like to focus on our research questions. What is the rate of first-line and second-line therapy failure? what treatment options can be offered to patients with second-line TKI therapy failure? And what is the effectiveness of TKI in the third-line therapy? So what are the predictors of the best response? As we know, TKIs have made a huge difference in patient survival. Most patients, from 70 to 85%, achieve full cytogenetic response on first-line TKIs. However, despite that, therapy failures occur, and they're mainly caused, and they mainly present in the form of poor tolerance, which causes the physicians to cancel the treatment regimen. About
That's what our data shows. About a third of the patients have to be transferred to the second line of the therapy, and about 30% need their second line change in the medium about 1.5 years. So what clinical recommendations suggest? Both international and Russian clinical guidelines show that in case of TKI failure in the second line therapy, we recommend to consider LOHSCT or transfer to TKI in the third-line therapy in case of absence of the optimal donor or the contraindications for HSCT or the age limitations. If we talk about the option of applying TKI for the second line of the therapy, we can be guided by the data of some central issues and the previous articles by our center and the data. About 20% of the patients who had 20% of the response on the third line of the therapy, and we enlarged the amount of the patients, and now we will present the results of the modern trial. Our trial had 104 patients from 5 hematological centers in St. Petersburg and the Leningrad region. Patients from resistance and intolerance of 2 lines of TKI in chronic phase of myelocene that were not included in the third line. So they were characterized by median therapy 23 months. Median of the second line was 15 months. Best response after the second line was 24% with a complete cytogenetical response. 90 patients had their response mutation were in most cases before the third line of the therapy. The median age was 51 years. The best response was minimum 20% and complete in 30% of the patients. As the efficiency indicator, it was great molecular response and overall survival in the subgroup of the patients with complete cytogenetic response. By the third line, we've studied the parameters of the deep molecular response. The analysis was performed by the describing Fisher method, and the curves were made by Kaplan-Meier, and the predictors of the complete cytogenetic response. We had one factor correlational analysis, and the prognostic scale was created for statistical computing hours. So we had 3 groups of the patient. The first one is without hematological response. The second group, hematological response, but without cytogenetic response, and the patients with different levels of cytogenetic response by the time of initiating of the third line. So 53 patients, and with the complete response, 53. Most of the patients got as the third line therapy, the second generation inhibitors, and the third line was within 17 months, and the period of observation was 24 months, and the median from diagnostics to the last visit was 90 months. So let's look at the results. So the first group, it was unfavorable group, no hematological response. We can see that 4 patients, 36% of the patients, reached the complete cytogenetic response. The time was 5 months, and loss of response was registered in 54% of the patient. Time till loss was 19 months. Also, the similar results in hematological response, but without cytological response. We can see 40% of the patients with cytogenetic response and 30% with great molecular response. Loss of response 30%. Time till loss 11 months. And the most favorable group, the group with a different level of cytogenetic response. Here you can see that the subgroup with minimal response and 63% reached the complete response. The time till response was 3 months, and with particular 5 months. And in the subgroup with the full cytogenetic response, half of the group deepened their response. Loss of response was observed in 34% of the cases. The time till loss was 14 months. Resulting data on these 3 groups, here you can see the advantage of the third group we took into consideration. We calculated the statistics without consideration of patients with a complete cytogenetic and big molecular response, only minimal response. So in the median of observation from initiation of the third line till the last visit, 20 deaths were registered, 3 after complications of HSCT. 3 deaths are connected. This subgroup were connected with the other responses. 2 cases, complications of cardiovascular system, and also complications after the secondary tumor process. So the transformation of the blast crease, 13% of them had it. To identify the most important prognostic factors, we used 1-factor analysis with Pearson correlation, and only in patients without full cytogenetic response with major molecular response by the time of the third line starting. This multifactorial analysis included 3 criteria. In this chart, we had the Bull evaluation. So the first group was low risk from 0 to 2 points. 26 patients were there, and the high risk from 3 to 6 points. And we had 47 patients in this group. Here you can see the resulting stage. 63% of the patients in the low group of risk reached the full cytogenetic response compared to the high group risk. You see that by the first year of the therapy, more than 50% of the patients in the low risk group reached the complete cytogenetic response. Also, there were significant differences in the overall survival. Here you can see that the 3-year overall survival in the low risk group was 90%, and in the high risk group only 65%. Thus, we have the following conclusions. About 30–45% of patients do not respond to the first-line therapy. About 50% do not achieve complete cytogenetic response on the second line. If we need to use the TKI in the third line, yes, we need to use them. It's confirmed. The patients who do not have candidates for allogeneic HSCT, it's quite confirmed. The overall survival is significant, and it correlates with the depth of cytogenetic response on the third line, and the frequency of the full response. Cytogenetic response was 16%, that is significantly lower compared to the 63% with a minimal cytogenetic response. Thus, we had 3 most unfavorable factors. It's the absence of cytogenetic response before the third line, absence of hematological responses. Those are the most unfavorable factors for the full cytogenetic response by the third line of the therapy, confirmed by our scale that we developed. Thank you very much, my dear colleagues. Thank you, the colleagues who helped me in this trial. Thank you.
Okay, thank you. Was an interesting study, I must say. I have a few questions, if I may start. You said they are resistant, they don't respond, and then they die. What do they die of? Do they have progressions? Is there blast crisis? Did you analyze this?
Yes, we analyzed. Among 20 patients, 11 deaths was from the progression of blast crisis and accelerated phase, and 6 from the other reasons, and 3 after the complications of allogeneic stem cell transplantation. So we have 11 progressions.
11 progressions, yeah. Then there are now additional markers for progression. We know that there are additional chromosomal abnormalities in the course of the disease. Did you have a look at that?
Yes, we evaluated that. We evaluated all the 104 patients, and we have only 19% of clonality. And we just adjusted it to our multifactorial analysis, and we just didn't see the significance of this.
I mean, clonal hematopoiesis, this is not enough. We now know that there's clonal hematopoiesis, which does not interfere very much, but then there are also high-risk additional chromosomal aberrations. This is now popping up in a number of studies. Can you say anything on that? Did you have a look at what the additional chromosomal abnormalities were? I know there are papers in the literature that did not differentiate. Also one from MD Anderson, and that causes a lot of confusion. You have to look, at the...
Yes, we have looked about clonality.
At the type of
progression.
At the type of additional chromosomal aberrations. For instance, the high-risk aberrations
Yes,
is
of course. Yeah,
trisomy
yeah, I
8,
know,
a
yeah,
second Philadelphia chromosome, isochromosome
Yeah, yeah.
17, or
Deletion 7, yeah.
trisomy 19, and so on, and
Yes,
complex aberrant karyotypes. These are the, and also -7.
Yes, yes, of course.
Yeah,
yeah.
this is, you really have to look closely. Otherwise, the point is, I mean, it's just not your fault. In the literature, it sometimes is not very clear.
Yes,
but
I
just, you
understand
are
that.
young and you are starting, and it's just a suggestion that when you analyze resistance in several lines, that you also have a look at these additional chromosomal parameters, since they may be helpful. And if you, for instance, have additional chromosomal aberration,
Yes, we have looked at
then you should proceed to transplantation with much more certainty, much earlier, because
That's
there's nothing
absolutely.
else. Tyrosine kinase inhibitors do not help in that situation anymore.
Yes, yeah, that's true.
Yeah?
Yeah, we know that, and we evaluated this clonality.
Okay, that
Yeah.
was just a question and a comment. Anybody else who wants to? You, Dr. Morozova.
Спасибо большое. Как очень такой хороший,
Thank you very much for this really nicely designed and reliable study. You had many patients, all of them third-line patients. Did you frequently need to interrupt therapy because of hematological toxicity? Because these are advanced stage patients. Thank you for your question. We did look into the reasons, into the causes for therapy discontinuation. And in many cases, it was poor tolerance. The therapy was discontinued to 2 for 4 weeks in 36% of the patients. I have another comment, a small one. Of course, this scale needs validation. And it is quite natural that the group of patients that you are dealing with is a retrospective one. So it's difficult to claim to having the ultimate truth. But the study has shown that there is a group of patients who can achieve a good response on third-line medications. And those may be patients with some depth of cytogenetic response who can be referred to not so much allo SCT, but rather to they can be recommended for third-line TKI. But if for 3 months you don't get any cytogenetic response, of course you should consider the patients for allo SCT, allo transplantation. We start looking for donors for our patients while our patients are still on second-line medications, because we need to think ahead. These are the patients for who we don't have a good donor, maybe a GAPLO identical donor. And this group of patients may benefit more from conservative therapy with TKI rather than transplantation. And Professor Hellman, do you have an opinion? Because we would value it so much. Is there a group of patients who should be initiated on TKI rather than allo transplantation?
That depends. That depends on the situation. I mean, there are patient-related factors, and then also factors related to the biology of the disease. For instance, if the patient doesn't tolerate transplantation, then what can you do? Then you have to rely on third or even fourth-line therapy, and the best choice is ponatinib in that situation. And only if ponatinib is really failing, of course, then things get really difficult. Then you go to experimental therapies. And I heard, that at your center there are trials to test asciminib, for instance, but there are also in Moscow, I think PF-114. I mean, there are these new additional drugs, and I would use them. And then regarding biology of the disease, if you have a progression that is not due to a mutation that is responsive to a TKI, then you don't have any other choice. First, to rely on transplantation, but and if you have to transplant, but then if the patient doesn't tolerate the transplantation, you have a real problem, and then again, you have to go to experimental approaches. I think that's what it's unsatisfactory, but these are the limits of our current knowledge. Okay, so may I proceed if there are no further questions? Thanks again, Dr. Chitanava. And we now come to Dr. Morozova from here, from St. Petersburg, from Pauls University, from the group, from the Gorbachova Transplantation Center. Is that right? This is your institution.
Everything okay?
Yeah, okay. And she is talking on allogeneic transplantation for CML in chronic phase. And it's the results of her own research. Dr. Morozova.
Уважаемый профессор Хельман,
Dear Professor Hellman, dear Andrei, dear Elsa, thank you very much for inviting me to take part in this forum. Thank you for this fantastic opportunity to meet my colleagues. I would like to make some corrections. I will be talking about allotransplantation at all stages of chronic leukosis. We all understand that it's a difficult problem. Allo-SCT is indicated when the patient does not tolerate the available medications, or patients in the accelerated phase or the blast crisis phase. Ponatinib, unfortunately, is not registered for use in Russia, which makes the situation even more complicated. These are the data provided by our colleagues from Moscow, Anna Turkina. Patients with the blast crisis have a 39% survival rate, which is really very low. If we analyze all the data over the past several years, most of our patients were initiated, received transplantation in 1995, and there are only 12% of them left. Most of our patients undergo a blast crisis. Our patients sometimes receive transplantation after blast crisis, and they receive 2, 3, or 4 transplantations. These are our gurus, Professor Zange and Professor Kruger. Their study shows that the patients with blast crisis have really poorer prospects after transplantation. So do we or do we not give transplantations to patients with a blast crisis? And our answer is, if a patient can tolerate it, if there is a donor and there is no next chronic phase, an allo-SCT is indicated. Maybe my colleagues will correct me, but there is only one patient on therapy in St. Petersburg in this situation, and so far, unfortunately, we haven't been able to find a donor, either in the national database or in the patient's family. The 5-year survival rate for these patients used to be 15%. Now it has grown to 60%, owing to the supporting therapy, owing to the use of TKI in routine practice. The work, the study carried out by Professor Hellman showed that patients that receive a transplantation early have better disease prognosis. 3-year survival rate, according to German data, in such patients is really good. 97 to 85% is really impressive. Another study conducted in 2020, 138 patients, and our colleagues do not show any improvement in the survival rate in the chronic second or third phase, with better results achieved by patients who receive a transplant after a blast crisis. It's great to work with this group of patients, but as an honest doctor, I need to say that there are a lot of problems. We can lose our patients to poor graft failures, 7% of our patients. 9% of our patients may be worried about the malfunction of the transplant, which can have dire consequences. Honest data also indicate that despite good transplantations, 37% of our patients will relapse, and despite successful prevention, the transplant versus host reaction may be visible in 26% acute and 14% severe. ELSA has shown us some data about patients on cytogenic and molecular responses. On Beyond and bosutinib, cytogenetic response can be achieved in over 80% of the cases. There are data by a Moscow group, Vasily Shuvaev. The results are really good for bosutinib being used as the second, third line medication. ELSA has shown us good results on the ASSEMBLE trial, and our patients in the may also show really good results. Some interesting work was conducted in 2020 by our colleagues who proved that the second, third and fourth line medications are targeted at finalizing therapy, but every line puts a distance between our patient and the stop line therapy. Some of our patients did not did not receive inhibitors, but the number of TKI receivers is growing. Right now, and a lot of events, we analyze the clinical cases, such as do we not treat patients with transplantations? This is a patient that has received 6 lines of therapy. No cytogenetic response. Do we transplant the patient, which is going to describe itself as a method? The patient feels great, and in the absence of an ideal donor, and he has no such, just a haplodonor. As far as mutation 315 is concerned, we try to take a very wise approach to that. Survival rate in this group is 49%, 5-year survival rate. For blast crisis, just 9%. Yulia Vlasova confirms the international data that the chronic phase is not a counterindication for allo-SCT.
As for some new things in the allogenic transplantation industry, additional chromosomal abnormalities and early solution for the decision. I won't here talk about the results. They are published and registered. So Professor Hellman shows the therapeutic group, the changes in the survival of different groups. It's an interesting trial, but Professor Hellman's best result is that he's the first in the world who talks about the fact that it's a very significant indication for the change of the second, third lines of therapy, and its indication for allogenic HSCT. So we had the high-risk groups, we had the mutations in 88% of the patients, in 91% of the patients, pH positive cells and pH negative clone. Those were indications for the change for the therapy, but of course it was a good education for allogenic transplantation. It's a one-factor analysis. Patients who had in their history additional chromosomal abnormalities and they had worse indicators of survival. In this group, they had more relapses and more deaths. Not a single factor should be analyzed. There should be many factors, comorbidity, lines of therapy, and the lines of the donors, the compatibility, etc. But the factor of additional chromosomal abnormalities can be a factor that influences the decision to perform allogenic transplantation. So here you see we've got different patients. The blue one, it's the chronic stage, and the patients who had acceleration phase is the worst group compared to the group without additional chromosomal abnormalities. As for chromosomal abnormalities after allo-HSCT, only in one case we had some success. In all the other cases, despite all our efforts, all our patients died. In the conclusion, I would say that allogenic transplantation is an effective therapeutical option. It has very strong education for the patients, but the chronic phase should be considered very personalized. And what was discussed by Professor Hellman, and we consider it right now, that mutations and abnormalities should be a significant indication for consideration of the therapeutic characteristics. I would like to thank my colleagues, especially Boris Afanasyev, who really made a lot to have such great results in Russia. Thank you very much.
Thank you, Dr. Morozova. I mean, that was a broad overview, and of course, you know, I'm quite excited, you know, that you analyzed high-risk ACA in the context of your transplantation. I think this is an interesting and useful information. So, are there other comments and questions to Dr. Morozova? I also thought, you know, it was nice to mention Boris Afanasyev, because he was very supportive of transplantation in St. Petersburg, and they had this Raisa Gorbachev Transplantation Center initially for children, but I think lately not only for children, also for adults. And I think that was pioneering work. I followed that for many years, and well, now last year he passed away at a very young age.
Yes.
I mean, 72 is no age these days. I mean, for those young faces, you know, that might seem old, but if you are that age, you don't feel old. So, if there are no further questions, you want to say something? A question, yeah, okay.
Елена Владиславовна, спасибо.
Thank you very much for your wonderful lectures, Елена Vladislavna. Just a practical question. It's obvious that you don't have enough data, but in your practical life, in chronicle phase or in the other phases, after allogenic transplantation, do you indicate prophylactical inhibitors of tyrosine kinases or not? What does it depend on? So you've seen the data, more than 60% are transplanted after the blast crease. So after opinion, maybe not favored by Dmitry Matorin, of course we prevent the early relapses. We indicate gazatinib in 70%. And as for the period, it should be discussed. So we can stop it, but in general it's about 2 years, and only a very few patients do not get it. They have intolerance to imadasanib, and our patients have the interthoracical admission of triplet. And we had another offer. We would like to compare the efficiency of the inhibitors of the second and third line in the chronicle phase. And I think it would be very interesting. Thank you for invitation.
If everybody is now happy and has asked the questions he or she wanted, we can proceed to the last presentation. That's given by Dr. Samoeva from St. Petersburg on therapy for blast crisis of CML own data. And of course, we know that this is a very hot but also very difficult topic. So, Dr. Samoeva.
Большое спасибо, профессор Хельман.
Thank you very much, Professor Hellman. Dear colleagues, allow me to present the results of our study on the treatment of blast phase of CML. Our department, starting with 2009, deals with the therapy of these patients. 46 patients with blast phase were treated in our department. Here you can see the patient's characteristics. So as for the age, very young cohort. The median was about 34. The ratio men-women 4:1. Most of them had the chronicle phase. 4 patients had the development of acceleration phase in the onset, and 4 of them had the onset with blast phase. I would like to note that 15 out of 46 patients had the acceleration fed before the onset. The blast crisis was within 30 months. Out of 15 patients, 8 of them had this phase determined only according to the presence of chromosomal abnormalities, but they didn't do anything about it. Also, when we were analyzing the period from the onset of the disease to the TKI therapy, we had a large group of patients who had them started very, very late. Analyzing the patients, we had this cohort of the patients who had the TKI therapy started in the period of chronicle CML. We had 10 of them, and they had a prolonged chronicle phase before any TKI therapy. And although this period before blast crisis was twice as long, it didn't affect it statistically. But in general, they had very late development of the blast crisis, and although there was no significant statistical values, we used it as an additional statistical value. It shows the TKI treatment prior to blast phase. 6 of the patients didn't get the TKI therapy. 4 of them had blast crisis in the onset, and 2 of them started the first TKI in the progression of the blast crisis. As the first line, patients got Intinib, and 14 got more than 1 line, and 1 had 4 of them before blast phase. Within the second line, patients got Nilotinib, Dasatinib, and 1 patient had even Ponatinib. Talking about the efficiency of the prior therapy, the patients who had the change of TKI treatment, mostly the reason for the change was refractarity, but most of the patients by the time of crisis had only 1 line therapy. 4 patients didn't have any additional information about the response. 22 patients gave us information about the achievement of complete hematological response. And most of the patients, the optimal response was achieved in 19 patients. Cytogenetic response is known for 9 patients, optimal in 6. 3 patients achieved cytogenetic response, and we didn't note any cytogenetic response in 4 patients. And the loss of cytogenetic response was noted in 7 patients, but we didn't change the therapy in them. And so as for the molecular response, it's known only for 3 patients, but these patients, in 2 of them, it was optimal molecular response, and 1 patient just on time. So refractarity for cytogenetic response was 4, and starting from the refractarity to the blast phase development, it took lots of time. So the median progression was about 6 months. This slide shows the results of examination of the patients of the blast phase. We don't have lots of cases. In lots of cases, some information, because the patients were examined not in our center but in other regions. As for mutational status, we know that the mutations were found in 14 cases, and most of them was T315I. In 7 of them, it was first found. The data of karyotype is present in 29 patients, and half of them had additional chromosomal abnormalities, Most of them was trisomia on the 8th chromosome or the inversion on the 3rd chromosome. In patients, in 5 patients, it was extramodular blast crisis and combined blast crisis. And phenotypic data shows that most of the patients had myeloid variant of the blast crisis, and 11 cases and 4 cases showed the other. And 4 patients, there were patients who didn't have a blast crisis. Talking about the treatment regimes of the blastic phase of chronic myeloleucosis, we divided the patients into 2. So some of them got only TKI, mostly dasatinib. 21 cases, patients got chemotherapy plus TKI. We used plus intensive and non-intensive regimes of chemotherapy.
In combined therapy, dasatinib was the most prevalent drug. In a number of patients, TKI were not prescribed, just chemotherapy. As far as the response is concerned, our retrospective study shows that about 82% of our patients reached the chronic phase with a median of 40 days. However, the range is from several days to 4 years. Cumulative frequency of reaching the second phase was 40%. 8 patients did not reach the chronic phase, with 6 patients dying at a median of 70 days. 2 of the patients did not reach the chronic phase. They received an allo SCT during the blast crisis. When analyzing the factors that might impact the likelihood of achieving the response, we analyzed the blast crisis, the absence or presence of additional chromosomal abnormalities during the blast crisis. We didn't find the factors to be statistically different, but during the lymphoid blast crisis, more patients reached the chronic phase. 100% for lymphoid and 74% for myeloid. Clonality did not show any differences. A combination of chemotherapy with TKI did not result in any benefits, which conflicts with international data. However, chemotherapy was administered sometimes when other regimens were found to be ineffective. So it was started fairly late in the course of the treatment. The acceleration phase impacted the achievement of the chronic phase. So patients with no prior chronic phase were more likely to reach it in 90% of the cases, compared with the 50% of patients who had an accelerated phase. TKI did not show any difference whether administered in the early or late phase. We also conducted a multivariate analysis of different factors impacting treatment efficiency in patients with blast crisis. The univariate analysis showed the presence of multiple lines of TKI in the patient's history, as well as the history of clonal evolution and the hemoglobin level. The multifactorial analysis showed that TKI and TKI only was statistically significant in terms of the outcomes. Out of 38 patients that reached the chronic phase, 20% of patients relapsed. The median time before recurrence was 3.5 months. Median time before LO-SCT was 3 months. We analyzed the same factors and tried to correlate them with the recurrences, with relapse. Blast crisis did not have any significant impact on relapse, but the lymphoid blast crisis was less likely to cause relapse compared to myeloid. The presence of clonal evolution did not show any impact. Relapses were also influenced by the preceding acceleration phase or accelerated phase. About 67% of the patients with the acceleration phase did relapse, compared to 44% of the patients without. The early or late inception of therapy for myeloleucosis patients was not statistically significant as to the outcomes. So there were no reliable impacts from any one of the factors when logical regression was used. Overall survival was about 19 months. 1 year probability of survival reached 73. Blast crisis therapy may involve LO-SCT. And the slide presents a diagram with data on patients who had a blast crisis. 2/3 of our patients with a blast crisis were referred to LO-SCT. They were typed. Another 11 patients were not referred to LO-SCT for this or that reason. But those who were, out of those who were, 9 did not receive it, even though they received a referral. It was the patient's decision that was based on the unavailability of the donor at that moment. Out of 20 patients, just 3 are still alive following a blast crisis and do not develop progression. However, 2 of the patients have been followed up for 2 years, and 1 has been followed up since 2018 and no progression. But this is the only exception. 16 of the patients relapsed. 1 patient out of the 20 in question died because of causes not related to CML. Another 11 patients received allogeneic transplantation in the second chronic phase. So 30 patients received transplantation, but very few of them in the chronic phase. So I would like to reiterate what Elena has said. LO-SCT has obvious advantages compared to conservative therapy. However, when you analyze the results of SCT on our cohort, we observed that the actual timing of the transplantation may make a difference. So we have a cohort of 26 patients that received transplantation in our center. And after the first blast crisis and the second chronic phase, the patient benefited from LO-SCT. Other patients had much poorer survival rates at 10% per year. The patients that were given a transplantation and the blast crisis had the poorest prognosis because of lethality and the poor state of health of these patients. The earlier late the type of transplantation, gaplo transplantation and allotransplantation did not show any differences in terms of efficacy or safety. At present, haplo transplantation is an alternative if no donor can be found from within the family. To sum up, our retrospective study has shown that the history of preceding acceleration phase, multiple TKI therapies, and hemoglobin level at the time of BP showed impact on efficacy of therapy. However, no difference was found in the efficacy of blast crisis treatment regimens. However, our data are retrospective and demonstrate some kind of artificial patient selection procedures. So bone marrow transplant is the best strategy. Following the optimal timing is following one blast crisis in the chronic phase. And I would like to thank my colleagues from the Institute of Hematology. All of them were actively involved in treating the study group of patients. Thank you very much. And now I would be happy to take your questions.
Thank you. That's an interesting study. I mean, it's retrospective, but you know, there are very few prospective blast crisis or randomized comparison of blast crisis around. So, you know, I think this is probably the way to proceed. What I was impressed about was your early curves, which you showed, where you showed these high levels of regaining chronic phase. You called it chronic phase, and later in your presentation, you started calling it second chronic phase. Why did you call it chronic phase in the beginning and second chronic phase later in? You didn't notice, just accident?
That was just accident.
Accident,
it was
yeah.
Second chronic phase.
Because in general, once you have blast crisis, you know, and then you reach chronic phase again, you call it second chronic phase. Yes. And so it's quite clear
it's really
that blast crisis involved. Yes. But nevertheless, you know, I was impressed by the high level of second chronic phases you gained. But then at the end, you said there were relapses, but that doesn't show in your initial curve, you know. I mean, apparently that came down later again. You had a high level, a plateau of chronic phase, but it didn't go down. Yeah. It should go down, actually, you know, if you have relapses, or that was not evaluated. Just in the beginning, you know, this impressive high level of chronic phase, 80 or 90%, you know.
I think a very short duration of second chronic phase. So the most patients without transplantation will relapse again to blastic phase.
Yes.
Okay, Dr. Morozova, you have a comment?
Спасибо большое, очень хорошие данные. Спасибо, что докладываете продвинутые фазы. Никто на себя, так сказать, не любит брать эту тему. А у меня такой вопрос. Я понимаю, получали больные лейкозные протоколы, там автоматически идет профилактика нейролейкемии, а те больные...
But the patients who had low doses of Citazar and had TKI therapy, did they have any prevention on leukemia? I would like to say that the start of the treatment was not in our institutions but in the region, and when we admitted the patients, even if they had neural leukemia, we had prevention, and before allogeneic transplantation we provided it. But as for the information about regular prevention of neuroleukemia, we don't have this information. We automatically consider them to be as non-receiving any treatment before admission to our institution, and we started it by ourselves.
Well, you know, what I like to comment on your presentation is, you know, that you have a very good long-term survival. And this agrees with an observation we also have made with the German CML study group. If you really concentrate on the best treatment available for blast crisis and progression, if you treat really early enough and if you treat intensively enough, you know, outcome tends to become better. So you have about 30% long-term survival of your patients who got an early TKI and who were treated adequately, and I think this is very good, you know, that is promising, and maybe just continue.
Thank you.
Okay, well, you know, there is in the program some additional time, I think 40 minutes for questions and answers. I think this is a little more than we really need, because most of the questions were already asked, and I commented when I felt I should. And in addition, you know, I couldn't stay until 3:30 because I'm supposed to be in another session at 3:15. So I think, you know, we are, at least from my point of view, very well in time, but we still have left, you know, a few minutes if somebody wants to raise some additional questions, you know.
I have a question, Professor Hellman. You mentioned about possibility usage of blinatumomab in the therapy of blast crisis CML. Do you have some information, maybe some data?
Say that again, you know, I didn't realize that it was addressed to me. I'm sorry.
Вы упоминали на прошлом симпозиуме.
You mentioned that there is data about blinatumomab in acute blast lycosis with the AP of CML. Do you have any additional information?
Now, if you have accelerated phase first and then blast crisis, that this is a worse outcome, or how did you you know, I'm still not quite clear. Say it in English. I mean, you speak English very well, you know.
Doctors use blinatumomab in the therapy of Philadelphia positive acute lymphoblastic leukemia.
Okay, you know, yeah.
Do you have information about possibility of treatment Phi
In lymphoid blast crisis?
Yes, in
No,
lymphoid
I don't
blast
have-
crisis.
I don't have any information. I've asked that same questions to Dr. Buchelt and Hölzer and Kantarjan, and, you know, I didn't get an answer. Maybe, but that's already, you know, I asked that a year ago, you know, but I'm not aware of any data on that.
Yeah.
But
Thank you.
blinatumomab, of course, you know, this is a very good treatment, you know, that is just a breakthrough with ALL treatment. And so it might well be worthwhile testing that in blast crisis. At least, you know, I'm not aware that we are doing it in Germany, but, you know, I'm not anymore in charge of the German CML study group, you know, that's Sausel and Hochhaus who are doing this, so I have to be. But anyway, I can't answer. Okay, so if there are no further questions, I thank you all for your very interesting presentations. And, well, I adjourn. Thank you.
Thank you.
Профессор Хельман, поскольку...
Professor Hellman, as Andrei Yurievich could not get connected, I would like to thank you for your coming, for this wonderful monitoring of the section. Thank you very much for your attitude.
And an honor. Thank you. Oh, yeah, fine, you know.
Там, коллеги, вы нас сфотографируете? Конечно, да. Не обязательно, да. Тамара, Оля, Дарина. Ян.
Between the two ladies, you know.
Роман.
The two senior hematologists in St. Petersburg.
Да. Давайте все, да. Роман, может быть, вы нас фотографируете? Может быть, вы нас фотографируете? Можно попросить? Да.
Okay. You know, so all the speakers, yeah, this is true. You know, good idea.